The next question is, describe the effects of pharmacokinetics and the potential clinical implications and provide relevant, the effects of obesity and provide relevant clinical examples. So, morbid obesity, the question didn't ask for morbid obesity, but morbid obesity is greater than 40 and 35 with comorbid. Then you talk about, so when you think of obesity, you can't forget liver cirrhosis or a non-alcoholic fatty liver disease. When you talk about kidney failure, you can't forget uremia. Okay, so these are just things that you have to remember. So absorption, you got oral, delayed gastric emptying, slower absorption. Non-alcoholic fatty liver disease reduces first pass metabolism, so increases oral bioavailability, plus or minus portosystemic shunt. That is, it's an operation. Topical, you have poor vascular supply, you have to the fat, and so you have slower absorption topically. Inhalation, because the question didn't actually ask about any particular drug, you just said obesity. So inhalation, reduced FRC, increased minute ventilation, and FRC ratio, so you have increased uptake. Remember, because time constant is FRC over minute ventilation. So if you have increased ventilation and reduced FRC, then what happens? You have shorter time. So you can say reduced, counteracted by increased cardiac output. Distribution, you have increased lean body mass, increased extracellular fluid, means VD for hydrophilic drugs. Increased fat, VD for lipophilic drugs. Body composition, so 2/3 the total body water, 1/3 is fat. Increased total body weight, increased fat mass linearly, but lean body mass plateaus at 40. Total body weight. So no, it's not water in fat. So if I said water here, ignore it, right? Then you have protein binding. You have increased alpha-1 glycoprotein because of the chronic inflammation. Decreased unbound drug, particularly basic. Cardiac output is increased because of low peak plasma concentration. Remember our mnemonic, COP. So cardiac output, increased distribution, protein binding, and then pH, which is not relevant here, and then body composition, or like a special population body composition. Then hepatic metabolism, we said HSP, right? So hepatic metabolism increase in phase 1 and phase 2. Metabolism, however, decreased if there's cirrhosis, obviously. HbF is increased, so increase of high HER drugs, such as propofol, increased due to increased liver volume and increased cardiac output. And remember, HS, we said cirrhosis, and P is pseudocholesterol. So you have increased activity, increased metabolism, hence use total body weight for sex dosing. Now, see, if you forget cirrhosis, it's fine because we have the mnemonic HSP. So you're like, S, oh yeah, cirrhosis. Oh crap, I forgot to talk about it. Okay, so that's fine. Elimination, renal excretion, increased renal blood flow, increased tubular secretion. Example, ciprofloxacin. Decreased tubular reabsorption, increased GFR, therefore increased tubular flow, reduced reabsorption, so lithium. So this can be confusing. When you're talking about renal elimination, remember tubular secretion. So if there's an increased GFR, then the tubular will be secreted, so increase of tubular secretion, but you have reduced tubular reabsorption, so you have less of the stuff going back into the blood, right? So you have it being secreted, but you have less reabsorbed into the blood because you have increased GFR, right? And then you have biliary excretion. So we talked about non-alcoholic fatty liver disease, decreased bile synthesis, decreased bile excretion, example in vecuronium. Inhaled excretion, fat is kinetically slow, so you have accumulation of volatiles. And then PD factors. Did it ask for PD factors? It actually only asks for pharmacokinetic factors, so we don't have to talk about PD factors. But clinical relevance, induction dose should be based on ABW or lean body mass. If you're using IBW, you're going to get underdose. If you use TBW, you will get overdose. Volatile with reduced lipid solubility, hence increased onset and offset. Use MASH model, which are based on V1 and total body weight. Schneider model uses a chain formula, which is paradoxically low BMI. Hence, maintenance dose is ABW or TBW. Such dose is based on that because of the increased pseudocholinesterase. So, just as a point here, induction dose should be based on adjusted body weight or lean body weight. Why? Because V1 is important plus V2, and V3 is less important for induction. Important. Note, lean body mass does not consider increase in V3. Okay, but obviously total body weight does, and adjusted body weight is more relevant in maintenance because it does include the V3 component. Like, I guess to a certain extent, it's mainly TW that includes the V3, but adjusted body weight assumes that LBM is linearly, so that's why you get overdose. But it does obviously include the total body weight in their formula, right? Because you have, where's the formula? You have IBW plus 0.4 T by EW, so it does technically include V3.